Okay, so let's start into the respiratory system. And usually some good things in here. So understanding the anatomy and function of the respiratory system will help in assessing and treating patients with respiratory disorders. Great. And I'm sure they're going to follow up with a cute video. All right, before we start the video, though, I want to point something out. Ventilation is a term that means moving air. All right. Taking air through your nose, through your trachea, down through your bronchi, into your lungs. That's ventilation. In anatomy speak, the moving of air is ventilation. That's not respiration. In this chapter, it's going to be confusing because we're like, oh, the lungs are inside of you. Well, we call what happens at the surface of the lungs the exchange of gases, oxygen and carbon dioxide. We call that external respiration. Why? Well, it may be inside the chest, but that's air that just a second later you're going to breathe out. That's external. The connection to that air and the air on the outside of your body, that's all the same air. So that's external respiration. Internal respiration is not what happens at the lungs. In anatomy speak, we use that for what happens at the tissues, where you're delivering oxygen to the tissue and picking up the waste carbon dioxide that it made. That's internal respiration. Anyway, so you've got that, the most confusing part of that class, you've already got that. Let's do the little video and then jump in.
Every cell in your body reflects.
Right. Okay, so let's move on. The major functions of the respiratory system, supply the body with oxygen for cellular respiration, and dispose of carbon dioxide, which is a waste product made in cellular respiration. The respiratory system and the circulatory system, they're coupled. They work together really closely. We also, in the respiratory system, we have olfaction, meaning sense of smell, and speech. We form our words using the respiratory system. All right, so 4 processes in the respiratory system. Pulmonary ventilation, that is the moving of the air in and out that we just talked about. External respiration, that is the exchange of gases between that air and the lungs. That air, which is now in the lungs, and the blood. Then the circulatory system does transport and internal respiration, where you are exchanging gases between the tissues and the blood. Okay, so yeah, we've got that. We understand that. That's straightforward. Ventilation, external respiration, transport, internal respiration. And if they wanted to continue again, they would then have another transport, and then you would do another external respiration. Anyway, so we're going to go fast through the functional anatomy, then we're going to do the physiology. But your major organs in the system, you have the upper respiratory tract, the lower respiratory. Upper is the nose, the nasal cavities, the paranasal sinuses, which lighten, warm, moisten, lighten. We might as well do that too. Sinuses are going to warm air, moisten air, trap mucus, and the depending on the size of the sinuses, they might do a whole lot to lighten the head. That's why if you look at, say, an elephant skull, where they have those heavy tusks, they have a giant frontal sinus to make the head lighter. Anyway, um, but the sinuses and the pharynx. The pharynx is the whole space from in back of the nose down to in back of the voice box. We call the part in back of the nose the nasopharynx, the part in back of the mouth the oral pharynx or oryngopharynx, and the part in back of your Adam's apple, part in back of your larynx, the laryngopharynx. Anyway, your lower respiratory is the larynx, the trachea, the bronchi, and the little bronchioles that branch off of it. You could have up to 20 or more, like bronchi break into, your primary bronchi, which is divided into secondary, which is divided into tertiary bronchi, blah, blah, blah. Like 20 subdivisions would not be unreasonable. Anyway, and then you have the lungs and the alveoli. But, oh, yay, we're going to have a pretty video showing it. Oh, with no sound. Okay, great. Yeah, we've got that. All right, I will pause it when it comes around again and we'll talk. Okay, no, don't do that. Come on, do the thing. What? Why will it not allow me? We'll give it one more try and then we give up. No, it works. It just won't move. Okay, what I was trying to show you right here, this is the nose and this is the nasal cavity. Behind the nasal cavity, this would be the nasopharynx, right here behind the nose. Now, this is the mouth, okay, and the palate is the floor of the nasal cavity, the roof of the oral cavity. In back of the mouth and back of the oral cavity, we have the oropharynx right here. And right here is the larynx, okay? And we have the laryngopharynx is the space behind that. The larynx is like a switching station where you decide if things are supposed to go down the esophagus, down to the stomach, or down the trachea, down into the lungs. All right, it wasn't that complicated. All right, let's move on. So here we have the picture, and I realized that all that fumbling I was doing to try and stop the video wasn't necessary. So let's point out some other things. The right lung has 3 different lobes. The left lung only has 2 lobes. Another way of saying that, the right lobe has 2 fissures dividing it into 3 lobes. The left lung only has 1 fissure. Why? Well, I'm not 100% certain, but you see how there's this spot here? We call it the cardiac notch because that's where the heart is. The heart is not way over where we pledge allegiance by putting our hand over our nipple. It's closer to the center. It's not dead center, but it's a little off center, enough that the left lung is a little smaller. It's missing some tissue at this cardiac notch. Because it's less tissue, we think you don't need to make another lobe there. Anyway, so the voice box area up here, the switching station, decide what goes where. That's all the larynx. And coming down through the trachea, the human trachea has C-shaped rings of cartilage down it. And the backside, I should turn it this way. The backside right here where it's not a C, that's tissue. That's muscular tissue. I'm talking about this wall right here. So around here, cartilage, 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 with this back wall, soft tissue. Why? That's the same wall as the esophagus. You can expand as food goes through there. The esophagus, the interior, the front of the esophagus is attached to the posterior of the trachea. Now, other species is different. Dolphins, whales, they would have a complete ring of cartilage. Talk to me later if you want to talk about the house and the whys. But anyway, you've got that. So you know the number of lobes, you know the shape of these. Also, the higher up you are in the respiratory system, this cartilage up here is almost all cartilage, almost no smooth muscle. Once you go down and it branches and branches and branches and branches again, when you get down into the lungs, these little bronchioles, um, the smaller they get, the higher the proportion of muscle becomes and the lower the proportion of cartilage. What I'm saying is that you can do bronchoconstriction to control airflow using what's happening in the little bronchi, the little bronchioles. All right. The trachea, you don't do that. All right, let's move on. Okay, so table 22.1 and 22.2, it goes through those upper and lower respiratory system. Talks about what they're used for. The nose produces mucus. We say, what's that for? That's to trap incoming dirt and things, keep them from getting in your lungs. It also warms, moistens, and filters the air that's coming in. And it is the space inside. Air vibrates around, and that's part of what forms your the sound of your voice. If you want to take out the nasal system and the resonance in the nasal system for forming your voice, just pinch your nose, and now you have what your voice sounds like without the resonance. So that's what they're talking about. The nasal cavity, the roof of the nasal cavity, also has your olfactory epithelium. Fancy way of saying the epithelial cells that are sensing smell. If you remember from AP1, you actually, that part of the skull is perforated by many, many holes. We call that's the ethmoid bone, and we call the spot there where the nasal nerves are passing, the olfactory nerves are having extensions into the epithelium below, going through those little holes. We call that the cribriform plate of the ethmoid bone. Anyway, paranasal sinuses, para means next to, and we already said that they lighten the skull. In some animals that's super important, us not as much, but they might also warm and moisten and filter the incoming air, just like we were talking about. The pharynx, connecting the nasal cavity to the larynx, three divisions: nasopharynx, oropharynx, laryngopharynx. Again, you've heard that. This is also where the tonsils are. I did not mention that. So we'll talk about tonsils. You have at the base of the tongue, the lingual tonsils. You have at the sides of the mouth, up at the palate, the palatine tonsils. And above that, in back of the nasopharynx, you have the adenoids. So, um, all right. So the larynx is the group of cartilages where your sound is produced. It also is where you decide things coming in the mouth. Are we sending them down to the lungs or down to the stomach? The trachea is for moving. Sorry about that. For moving air, conducting air from the head down into the chest. There's no gas exchange happening here. Um, the bronchial tree, left and right bronchials, they subdivide. Like I said, you could have up to 20 different levels of subdivision, but they get smaller, smaller, smaller. They you once you get down in there, you don't have cartilage, but you have smooth muscle. That's why you can do bronchioconstriction and bronchodilation to control the flow of air. The alveoli are the sacs where we do the gas exchange. Um, let's see. Lungs, we have two of them. You know that the right one is larger than the left one, has three lobes, the left one has two. Um, I didn't mention this, it's the elastic tissue. When you stretch it, it's like a balloon. You can blow up a balloon. You don't have to spend any energy. The balloon will return will return to normal size without you spending any energy. Lungs are the same way. If you inflate a lung, stretch it, fill it up, if you stop blowing into it, stop expending energy, that lung will return to its normal size, shoving air out. Anyway, and pleura are the serous membranes surrounding the lungs. Slippery, full of serous fluid. It allows the lungs to easily move when you're breathing, reduces the effort to breathe. All right, let's go through all this stuff. Upper respiratory system, you've got the nose. That's the only part that's outside the body on the respiratory system. What does the nose do? It provides a passageway for air to come in. It also warms and moistens the air. It filters and cleans the air. I'm talking about the mucus in the made by the mucosa. If you've ever not been wearing a respirator like you should, and you're working in the garage, maybe you're doing woodworking, maybe you're welding and then grinding metal. If you're doing that, you're inhaling a lot of metal dust particles. And at the end of the day, your snot will be black. Why? Because there's all that stuff you breathed in that would have gotten in your lungs if you didn't have all the mucus. So, filter, when we say the air is filtered and cleaned, we're keeping things from getting down in the lungs. Anyway, serves as a resonating chamber. We already talked about that. Um, olfactory receptors, we already talked about that. So it's divided into two parts: the external nose, that's the part I can grab here, and the nasal cavity, what's up inside behind that. Okay, so the external nose, we have the root of the nose. That's the area up here between the eyebrows where my glasses are sitting. Includes the bridge, the dorsal surface of the nose, the anterior margin, that means the front, and the apex, the tip. So great. Um, then we have the nostrils, also called nares. These are the holes right there. Um, these little grooves are the alae. The external nose is formed by nasal and frontal bones at the top. That form the bridge and the root. The maxillary bones on the side, and plates of hyaline cartilage on the bottom. This cartilage right here, it's kind of wiggly, but kind of tough. See, like this is cartilage, but this is elastic cartilage. And you can take your ear elastic cartilage, you can bend it around. It's really hard to do anything. You try to bend your nose too far, that's hyaline cartilage, it'll break. Okay, moving on. All right, epicranius, root and bridge of the nose, dorsum nasi, ala, apex. Oh, yeah. Okay, ala right there. Apex and nares. Great. Moving on. This is made out of your frontal bone, your nasal bone, the septal cartilage. That's the cartilage right here that you can wiggle. The septum, the divider, just like in the heart, we had a interatrial septa between the ventricles and interventricular septa between the ventricles. Here we have a nasal septum that's part of the nose, but divides us into a left side and a right side. Okay. Yeah, this is all pretty straightforward. So the nasal cavity is within and behind the external nose. We have a nasal septa down the midline. The nasal septa is at the front, formed by a septal cartilage, at the back by the vomer bone and a perpendicular piece of the ethmoid bone. Remember the hole on top, sorry, the top surface, the ethmoid plate, sorry, the cribriform plate of the ethmoid bone, that's where the olfactory bulbs sit. So posterior nasal apertures, also called choana. These are the holes at the back of your nose where the nasal cavity joins the nasopharynx. The roof of the nasal cavity is formed by the ethmoid and sphenoid bones. The floor is formed by the soft palate. Great. So a vestibule is an entryway. We're talking about the space, like this is a nostril, this is a nostril. The space right there, just above the nostril, the nair, is the vestibule, nasal vestibule. And this is lined with those disgusting hairs that you occasionally have to trim or pull out. The real name for those hairs is vibrissa, and they keep, it says, filter coarse particles from inspired air. What they're saying is big things, things like keep a bug out of your nose, you know? Um, the rest of this nasal cavity is lined in olfactory mucosa, and the upper area is has the olfactory epithelium. We said that. The respiratory mucosa is pseudostratified ciliated columnar epithelium. It has goblet cells, that's where we're making mucus, and lamina propria that has, well, there we have mucus, okay, seromucous nasal glands. What is the purpose of mucus? To catch things that are trying to get into your nose and breathe them out, get rid of them. All right, let's see. Yeah, that's fine. Do. Okay, so seromucous nasal glands contain mucus-secreting mucus cells and serocells. The serocells make a watery fluid that has enzymes. That'll help to kill things that try to get up your nose. Mucus and serous solution both have lysozymes and defensins to help destroy things that should not be getting in. The ciliated soles, it says, sweep contaminated mucus posteriorly towards the nose. The lining, literally, you have cells going passing the mucus to the back of the throat so you can swallow it down to the stomach and let the strong levels of hydrochloric acid destroy whatever was caught in the mucus. The air you inspire, inspiring means breathing in. The air that you inspire is warmed up by a bunch of capillaries. We already talked about that. Warm, moisten, filter. Okay. It's warmed up by all the capillaries and veins in the nasal cavity. And that's good because it helps protect the lungs. You don't want to breathe in cold air too easily. It's startling and harsh on the lungs. Anyway, nasal mucosa has lots of sensory nerves that can cause sneezing, force particles out of the cavity. Great. All right. The conchae, also called the turbinate bones. Let me They're talking about these right here. Superior nasal conchae, middle nasal conchae, inferior nasal conchae. These are the bones that are inside, and the air and those bones are covered with mucosa. That's the nasal mucosa we were just talking about that makes the mucus and all. But what happens is when you breathe air in, that air will be full of things you don't want to have go to the lungs. And as the air, say, bends and turns to go around those turbinate bones, it will have particles and junk that you don't want getting down into the lungs that won't make the turn very well, and they'll go crashing into the mucosa. And then the cilia will move it to the back of the throat where you can swallow it down and destroy it. Anyway, we did that. Mucous membrane, nasal cavity, respiratory mucosa. Yeah, we did that too. But yeah. Okay. So the mucus and the serosa, serosecretions, they contain defenses, they contain lysozymes. They can kill some bacteria before they even get into the body. This warmed air, this expired air is warmed, moistened, filtered, like we said. Nasal mucosa can have many sensory nerve endings that will cause sneezing to force particles out of the nose. If something does get in your nose, you will probably sneeze and get rid of it. So the nasal conchae are these scroll-like mucus-covered projections of bone that protrude medially from each lateral wall. What they're saying is, say, here's my nose, here's the septum down the middle. These conchae grow from the sides towards the middle and then spiral. Okay. You got three parts. We just looked at the pretty picture: superior, middle, inferior. The meatus is the groove below each conchae. All right. And the shape of them increases the surface area that is exposed to that the air is exposed to for warming and moistening. It enhances turbulence as the air spins around. Like I said, any dust, small bugs, things, they're going to not make the turn as well and slam into the mucosa and get stuck in the mucus. So, what is its function? Hey, we've already said that. During inhaling, you warm, moisten, and filter the air. During exhaling the air, you reclaim heat and moisture. You try to absorb the heat, absorb the moisture, so you don't just breathe those things out. Here in Florida, we don't care that much a lot of times about losing heat, but up in Michigan, when you breathe out, well, here up in Michigan, if you breathe in too fast, too hard, it hurts. Your chest actually hurts. Why? You didn't give time to warm and moisten the air. Well, say you breathe slower, great. I don't hurt. But now you're going to breathe out. You don't want to lose that moisture from the body. You don't want to lose that heat from the body. So those the mucosa over the conchae will try to reabsorb some of that. All right, paranasal sinuses. We're talking about the frontal sinus, the sphenoid sinus, the ethmoid sinus, the maxillary sinus. Hey, these sound a lot like the bones of the skull. If you memorize your bones of the skull when we did skeletal system, you know where these are. That's pretty nice. Anyway, paranasal sinuses form a ring around the nasal cavities. They lighten the skull that was already mentioned. They make mucus and they warm and moisten the air. Same thing as what's happening with the turbinate bones, the nasal choana, conchae. All right, so there we have the pretty picture showing the same stuff. Frontal sinus, sphenoid sinus, great. Here we have superior, middle, inferior. Here we have the grooves, the meatuses. It's all good. Nothing hard there. Not pointing it out, but this growth right here, I mean, they're not pointing it out here, but they probably should. That's not in the middle, that's off to the side, and there'd be one off to each side. Those are your palatine tonsils, okay? These are the tonsils that are commonly called adenoids. Anyway, moving on. So the hard palate at the front, closer to the teeth, there's bone. The soft palate back here, this is just soft tissue, just flesh. The uvula is the hangy downy thing in the middle of the roof of the mouth. That is an extension of the soft palate. The purpose of this is when you're swallowing, that will swing upward and close this passageway. It will cut off the nasopharynx from the oropharynx to keep, you don't want to like swallow and laugh and talking while you're drinking and you get soda up in your nose. If you've ever done that, oh my God, it hurts. So the uvula is supposed to stop that from happening. And further on, we'll talk below that about down about here about the epiglottis. A glottis is an opening. Epi means above. So the above the opening thing is a piece of hyaline cartilage, the same as this kind of cartilage. Piece of hyaline cartilage. Oh, I take that back. No, the rings on the trachea are hyaline. The epiglottis, which I was about to describe, that's elastic cartilage like the ear because it's super springy, springs back. Anyway, uvula keeps you from having fluid go from the oropharynx into the nasopharynx. The epiglottis keeps you from having fluid go from the oropharynx into the laryngopharynx. Let's move on. All right. Itis means inflammation. So rhinitis is inflammation in the nose, inflammation of the nasal mucosa. This is continuous with mucosa in the respiratory tract. So if you let these infections spread, they can go from the nose all the way into the chest. That's bad. You could also have this spread to the tear ducts, the paranasal sinuses. That could block sinus passages, causing sinusitis, inflamed sinuses. Let's be very blunt. Scuba diver's worst nightmare because you don't want to end up with a sinus squeeze. If you do get blocked passages, sinusitis, you could have the body absorb the air, and then you have a lower pressure area inside of the sinus. That's what causes a sinus headache. All right, the pharynx is a funnel-shaped muscular tube. Runs from the base of the skull to vertebra C6. Connects the nasal cavity and mouth to the larynx and esophagus. Made out of skeletal muscle. We've already said there are three parts. The part in back of the nose is the nasopharynx. The part in back of the mouth is the oropharynx. The part in back of your larynx is the laryngopharynx. All good, straightforward. So the nasopharynx has air going through it. It is lined in pseudostratified columnar epithelium. Great. The soft palate and the uvula will close the nasopharynx. They'll come upwards when you're swallowing and block the passage, prevent things from going up into your nose. You don't want half chewed up spaghetti going up your nose. It's not nice. The pharyngeal tonsils, also called the adenoids, are located on the posterior wall at the back. So the pharyngeal tonsils are in the nasopharynx. Then you have what they are calling pharyngotympanic tubes. In the olden days in anatomy, we used to call them Eustachian tubes, but the Eustachian tubes or auditory tubes, some people say, are tubes that go from the inner ear to the throat. They allow you to equalize the pressure in your nose. Equalize the pressure between your nose and your ears. Your ears. When your ears pop, what you're hearing and feeling is the release as the pressure is equalized between the two. Anyway, equalize pressure in the middle ear, open up into lateral walls. Great. All right, the oropharynx. This is for food and air. This is from the soft palate to the epiglottis. It's lined in stratified squamous epithelium. Why stratified squamous? Stratified squamous is the most abrasion-resistant form of food we have, form of tissue we have. If you have food or liquid rubbing against a substance, rubbing against your tissue, you want it to be a stratified squamous tissue. The reason is if you rub off an extra layer, who cares? You're probably 20, 30 layers thick, you know? And that's possible because the cells are squamous, they are squashed flat. And so instead of having like one or two cells to fill up this space, you could have 10 layers fill up that same space. So stratified squamous, good at abrasion resistance. An isthmus is a narrow area. The isthmus of Fosses is the opening into the oral cavity, the mouth. You also have the palatine tonsils. The ones I told you about are at the sides, lateral wall. And the lingual tonsil is the one at the base of the tongue. All right, so the laryngopharynx is below that. It is behind the larynx, the voice box. It's a passageway for food and air. It's behind the upright glottis. The upright epiglottis. It extends down to the larynx, the voice box, where it's continuous with the esophagus. And like I said, the best way to think of the laryngopharynx is a switching station, which decides if things in the mouth are supposed to go into the lungs or into the stomach. And because we have food passing through there, it's lined in pseudostratified, stratified squamous. Stratified means you have many layers. Squamous means they're squashed flat. You want, because food is going to pass through there, you want it abrasion resistant. Okay. This is straightforward. We've been through this. Infected and swollen adenoids. Remember, those are your tonsils that are at the posterior wall above the soft palate. So anyway, swollen or infected adenoids could block the air passage in the nasopharynx and force you to breathe through your mouth. When you do that, the air doesn't get warmed, moistened, or filtered before it gets to the lungs. If adenoids are chronically enlarged, both sleep and speech may have problems. Now, that was your upper respiratory system. Your lower respiratory system, you have your larynx, that's your voice box. Your trachea, that's how you conduct air to and from the lungs. The bronchi, those are the tubes below the trachea. and the lungs. Now, we divide this up into conducting zone, which carries air but doesn't do gas exchange, and respiratory zone, where we do gas exchange, where we do external respiration. So, what we're talking about here is respiratory bronchioles, alveolar ducts, and alveoli. Now, this term respiratory bronchioles, I want to make it clear. I talked before about bronchioles. I didn't mention respiratory bronchioles. You keep dividing to get smaller, smaller, smaller until you get to the respiratory bronchioles. The only difference between the respiratory bronchiole and the division above it that doesn't is that there's no gas exchange in a normal bronchiole, and there is gas exchange at a respiratory bronchiole. Um, the reason this happens is most gas exchange happens in little sacs called alveoli, and those sacs, a lot of times, they look like a cluster of grapes. Well, the respiratory bronchioles, you're still conducting air, but the walls are so thin that you'll have a single sac right there coming right off the bronchiole all by itself. If that's true, we call it a respiratory bronchiole. Bronchioles that don't have any alveoli on them, we just call them bronchioles. If the bronchiole has an alveoli on it, it's a respiratory bronchiole. Anyway, so the conducting zone cleans, warms, moistens, cleans, warms, humidifies, yeah, so moistens air. The respiratory is where we do the gas exchange. All right, so the larynx, from the third to the sixth cervical vertebra, it attaches to your hyoid bone. That's where you anchor your tongue. It opens into the laryngopharynx and is continuous with the trachea. Great, just it's all that stuff in front of the esophagus. There are three functions. You provide an airway, you route the air and the food into the proper channels. That's the work of the epiglottis, you remember? Um, and this is where our vocal folds are. What people commonly call vocal cords would be better described as vocal folds. The cords are tough ligamenty things going on at the top, and then you have mucosa coming down from those cords that we would call folds, so vocal folds. Um, the main part of the larynx, we've got 9 cartilages that are all hyaline, except the epiglottis, which I already told you it's elastic, so it's super flexible. It can go down, pop up, down, pop up. These are all connected to each other by membranes and ligaments. The thyroid cartilage, that's the biggest one. It's this big shield-shaped thing. The bump that moves when you swallow, that bump that's bigger in men than women, that is called the Adam's apple in common speech. What it really is the where what it is, this shield-shaped cartilage has this laryngeal prominence. That's what the Adam's apple is the laryngeal prominence of the thyroid cartilage. And yeah, I expect you to know that, the laryngeal prominence of the thyroid cartilage. Now, that's a singular, you have one thyroid cartilage. Below that, you have one cricoid, one big fat ring. But the others are paired. The cuneiform paired, the arytenoid paired, the corniculate paired. Now, I don't like the way they wrote these because I would always put arytenoid and corniculate together. The cuneiform are little curved, slender, off to the lateral wall, embedded in mucosa, just kind of stiffen it. And they don't, their main purpose is to provide some strength, some rigidity to the mucosal walls of the larynx. and they're really hard to actually see because they're embedded in that mucosa. But the arytenoid, those are the ones that when they move, when muscles pull on them to move them, it pulls on the vocal cords and controls the tension on the cords. So that's way important for speech, the arytenoids. The corniculate are little teeny tiny, think size of a kernel of corn or smaller, tips of the arytenoid. Like they're really the corniculate and the arytenoid are really separate cartilages, but the cornicular, the little, think of it as a cap. Think of it as a hat that is on top of the arytenoid. That's what the corniculate does. It's just sitting there. The muscles are pulling on the arytenoid, they're not pulling on the corniculate. All right, the epiglottis, epi means above, glottis is the opening or the hole. You already heard this is elastic cartilage like your ear. It's not hyaline cartilage. That's because it has to bend again and again and again and again and again. Every time you swallow and don't accidentally send fluid down to the lungs and choke and die, thank your epiglottis. It's what does the routing of where things go. It covers the entrance to the larynx where um, only the air going to the lungs should be. It covers that every breath you take. Sorry, every time you swallow. And the epiglottis has a lot of taste buds in the mucosa. Moving on. All right, so hyoid bone's up there, the Adam's apple, yeah, right there. The clavicle, remember that from skeletal system. That's your collarbone. The clavicle is the collarbone. So you have two clavicles that come together here in the middle. And the jugular notch, I guess I should have left that down there. That's the notch you feel where the two clavicles join. That's your jugular notch. All right, so we've got that. Moving on. The hyoid bone at the top. Now behind that, you have sticking up the epiglottis. There should be a lateral view. Sorry, a side view. Yeah, we have a side view. Okay, so cuneiform cartilage, corniculate cartilage, arytenoid muscle. Yeah. Anything else in here? Let's point out again. So the epiglottis is above the glottis, sticking up. The cuneiform, it looks like cuneiform writing. Is that? Mm. So, yeah, the epiglottis is above the glottis, and it will bend down and keep things where they should be. Make sure we don't inhale our meal literally. The cuneiform, here's the one that looks like cuneiform writing if you can find it, but it's super hard to see. Okay, let's move on. So here we have the vocal folds, the glottis is the opening, and we have the vestibular folds or vocal cords, false vocal cords. Then we have the vocal folds, the true vocal cords. Yeah, we've got all that. Okay, so how do we make a voice production? How we speak. Speech is caused by the release of expired air, of air we're breathing out. It goes past that goes past the vocal cords. Air goes past the vocal cords, and just like on a guitar, you can tighten the string and the note goes up. Well, if you pull on the arytenoids and tighten the vocal cords, the pitch of the voice goes up, the note goes higher. How loud the air is, that depends on how much air you are forcing past the vocal folds. If you're putting a little bit by, if you're putting just a little bit by like that, it's going to be like a whisper. If you put a huge amount of air by, that's going to be the loud noise. Okay. The pharynx, oropharynx, nasopharynx, sinus cavities, all of those can be used to vibrate. All those can be used as resonance chambers to help shape the sound of your voice. Yeah, let's move on. Let's move on. Okay, so sphincters function in the larynx, the vocal folds can be kind of a pseudosphincter to prevent air from passing. This would be during the Valsalva maneuver. You close off the glottis, the opening in the top of the trachea. The abdominal muscles contract, squeezing the air, squeezing on the organs, pushing, and those organs will rise and push on the stomach, and your intra-abdominal pressure goes up. And when you are doing the late night comedian thing, sitting on the side, sorry. What did I just say? Okay, glottis prevents exhalation. Abdominal muscles contract, pressure goes up. This stabilizes the trunk if you're trying to go to the bathroom or if you're trying to lift stuff. I don't even know what I said there. Okay, itis is inflammation. So laryngitis is inflammation of the larynx. The vocal folds are going to swell, and that'll make it hard to vibrate them, make it hard to speak. Changes your vocal tone, sounds harsher, and it's kind of still black. Where was I? Okay, so if you change the vocal tone from the inflammation, in severe cases, you can't even talk. You get the ability to whisper. You can't have proper talk. Laryngitis caused by viral infections, but could also be due to overusing the voice. Very dry air, a lot of bacteria around. Those can cause the types of problems. So yeah, tumors, inhalation of irritating chemicals, those can make it difficult to use your larynx properly. Now your trachea, it's from the larynx to the middle of the chest cavity, the mediastinum. It divides into two primary bronchi, a left bronchi, a right bronchi. The trachea is about 4 inches long, 3/4 of an inch in diameter. And because it's not a pipe, because it's made out of little rings, and those rings are attached by little pieces of individual connective tissue, that makes it pretty flexible. It can bend. This is important because we can move our head around. We can bend. The wall of the trachea is made out of 3 parts: a mucosa that a so the mucosa is the inner lining with the goblet cells. The submucosa, what's below that, and that's 16 to 20 C-shaped rings to keep the trachea from collapsing. The adventitia, and you're going to see this term again and again and again in anatomy, the outer layer that is all connective tissue. If we say that's adventitia, that's connective tissue that is anchoring the organ in place, making sure it doesn't change its location relative to what the other organs are doing. Okay, so trachealis. Yeah, trachealis would be the smooth muscle fibers that connect the posterior of the cartilage rings. Remember I said that in some animals like dolphins, it's continuous. When humans, it's not. Um, the trachealis can contract during coughing and push out mucus. Um, the carina are the last two cartilage. They're expanded. They're found at the point partway up where the trachea branches into the two bronchi. The mucosa or mucosa of carinae, they're very sensitive. Violent coughing will trigger if there is a foreign object that comes into the wall. Sorry, that comes into the area of the carina. And there we go. Yeah, we've got that. We got that. So you know the lining is pseudostratified ciliated columnar cilia because we need to move the mucus away from the lungs and towards the mouth. Mucosa because we are making mucus. That's how we're trapping bad things that don't belong. Lamina propria, that's the connective tissue that holds all that stuff together. The goblet cell, that is the cell that makes the mucus. Um, Yeah, so we've got that. You know the rings in the neck, the rings in the trachea are hyaline cartilage. We've got that. All right, here are the cilia, the hair-like cells. Those are the ones that move the mucus up and out of the lungs. All right, homeostatic imbalance. If you're smoking, you're going to destroy the cilia. That makes it really hard to get the mucus up where it should be going to the mouth, and instead it wants to settle in the lungs. You don't want that. So you're constantly coughing the mucus up. That's what smoker's cough is. If a person stops smoking, the cilia will usually grow back within a couple weeks and the smoker's cough will go away. All right. Tracheal obstruction, if something blocks your trachea, that can kill you. People have suffocated after choking on food. That's why we know the Heimlich maneuver, and we can use that for treating victims, like as a first aid thing, an easy one. Let's see. So yeah, Heimlich maneuver used to pull to pop out the food. If you do it wrong, you can crack ribs. Great. The bronchi in the subdivision, I said over 20. It turns out it's 23. So there are 23 subdivisions as you go smaller, smaller, smaller. And understand that the upper respiratory system has the conducting zone. It's where that branches further and then suddenly gets alveoli. Any part that has alveoli, we don't call the conducting zone, we call it the respiratory zone because that's where we can do gas exchange with the alveoli. All right, the trachea divides to form right and left primary bronchi. Where was I? They're divided to form right and left primary bronchi. The right bronchus is wider, shorter, and more vertical than the left. Why is it wider and short? Wider because you've got three lobes. You got to pass more air through there. But with it being more vertical, that's bad because if food does fall down the pipe, it's more likely to get stuck on the right side than the left because of the verticalness being steeper. Each main bronchus enters the hilum of a lung, that's a concave area. Each primary bronchus then branches into lobar bronchi, one per lobe, and then does night diving and self diving. Why am I going on diving? Okay. The hilus. The hilus is where the bronchi go in. There, blah. Leave the diving out. Each bronchi divides into lobar bronchi, secondary bronchi. You know that there are three on the right because you got three lobes in the lungs on the right. You know there are two on the left because we have two we have two bronchi because we have two lobes on the left. And each lobe of the lung gets its own bronchi. So, all right. Each lobar bronchus supplies one lobe. Yeah, we said that too. How much more do we have? Wow, more than I thought. Okay. Let's back up here. Let's see. Yeah, right there. That's where we were. All right. Hold on a second. No, it's not what I want. That's what I want. All right, give me a second. Okay, let's try that again. I just backed up a few slides. The homeostatic imbalance for here is talking about smoking and how it messes up the cilia. If the cilia don't work, then you have mucus that wants to get into the lungs, and you're going to have to cough all the time to hack that mucus up. That's where a smoker's cough comes from. And yeah, if you stop smoking, the cilia can regrow. It'll take a couple months. It says a few weeks. So yeah, assume a month and a half, 2 months at least. And then you'll be able to have the cough subside, cough go away. All right, moving on. All right. If you get something lodged in your trachea, like a piece of food that you're choking on, people have to do the Heimlich maneuver. That's the thing where they reach around you from behind and may close their hand kind of like a fist. It's not a true fist, but then put their thumb out and put their hand here and they pull that in below your diaphragm. The goal is to go into your solar plexus and up. Anyway, that process can dislodge the food, use air pressure to pop the food out. It's simple to learn, it's easy to do. But if you do it wrong, you're pulling hard enough, you might break the ribs, crack the ribs a little bit. All right, moving on. So 23 levels of branching as the bronchi go down to the bronchioles, and then the respiratory bronchioles, and then the terminal bronchioles. So yeah, lots of branching. And the areas that carry air but don't do any gas exchange are the conducting zones. The areas that start to have alveoli where you start to exchange gases are the respiratory zone. Conducting zone structures. The trachea divides to form left and right primary bronchi. The right one is wider, which makes sense because it's going to have three subdivisions, not two. It's also more vertical. That's why when things get stuck in a bronchi, it's more likely to be the right one because it's easier for stuff to fall into. The notch in the lungs where the bronchi come in, that's the hilus, same as you saw in other organs, kidneys, say. Each main bronchus will branch into secondary bronchi, one per lobe, so that's why you have three on the right and two on the left. Okay. Each lobar bronchus branches into segmental or tertiary. Well, segmental would be the tertiary, the third division bronchi, and those divide more and more and more. Any of the divisions that go down. Remember, we could have 23 divisions. Once you're getting down to things that are smaller than a millimeter in diameter, we tend to call them bronchioles instead of bronchi. The ones at the very end are terminal bronchioles. That's the last division. They are half a millimeter in diameter. All right, so there we go. Pretty drawing. If we haven't mentioned it yet, the name for the bottom of the trachea where it branches off into left and right primary bronchi, that's carina. The names of the lobes, we haven't done that either. It's pretty simple. The one at the top is the superior lobe. The one at the bottom is the inferior lobe. On the right side, you also have a middle lobe. You don't have a middle on the left. Okay, so we've got that. The conducting zone is everything from the bronchi to the bronchioles. There are changes. In the upper part of the conducting zone, you have big cartilage rings and very little muscle. And at the other end, you have almost all muscle with no cartilage. So the cartilage rings, as you move from the big trachea down, 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 the cartilage rings are going to get reduced to plates. Once you get to the bronchioles, the cartilage is entirely gone, and you just have elastic fibers instead of cartilage. And then, of course, you have a ton of the smooth muscle. The epithelium is going to change. You're going to go from pseudostratified columnar to cuboidal. Cilia and goblet cells become more sparse. What that means, if you think about it, is you're making less mucus and have fewer cells to move the mucus around. In other words, most of the stuff that you keep out, you catch in the upper part of the conducting zone. The amount of smooth muscle will go up. It lets the bronchioles provide resistance to air passage. You might say, why would you resist airflow? Well, it's simple. If you have a damaged part of the lung, don't send too much air there. If you do, you can't get much oxygen into the blood from there. I mean, you send enough to keep the cells alive, but reduce the amount of blood flow, so the amount of airflow there, and reduce the amount of blood flow there. Send those things to places where you can actually do gas exchange, which is the job of the lungs. Anyway, so the at the bronchial end, at the narrow end, you have lots of smooth muscle and no cartilage at all, and some elastic fibers. All right. The respiratory zone is where the terminal bronchioles, the last ones that are just conducting, feed into respiratory bronchioles. They're named respiratory because they have some alveoli on them. Okay. Those go into alveolar ducts, which have lots of alveoli on them. The bronchioles go into alveolar ducts, which go into alveolar sacs. The duct is the central airway through a cluster of sacs. Alveolar sacs have a cluster of alveoli. The 300 million alveoli are most of the lung volume. The alveoli are where we actually put oxygen into the blood and take carbon dioxide out. So here is a lovely drawing. The individual alveoli that together make up the alveolar sac, and the alveolar sacs are attached to alveolar ducts, which are attached to respiratory bronchioles. What's the difference in this respiratory bronchiole right here and this terminal bronchiole right there? I mean, they're super close to each other. The difference is there are a couple alveoli on the respiratory bronchiole, so we're starting to do the gas exchange. All right. Here is an actual histological slide showing the difference. The respiratory bronchiole is passing into the sac. This is where the actually it's coming from the sac. The air is going this way to the alveolar duct and then the individual alveoli. So this super spongy area, your lung is very, very spongy because it's all airspace and alveoli. And remember, they are super flexible, super elastic, I should say, not flexible, super elastic. Okay. And inside, I hadn't mentioned this yet, inside of the alveoli, you have alveolar pores. They're going to release surfactant that is going to make it easier to inflate the lung, make it less likely for the sides of the alveoli to stick together. All right. The respiratory membrane, that is what the alveoli are made out of. There's a blood barrier that consists of alveolar and capillary walls along with their fused basement membrane. The whole thing is very thin. It's like half a micrometer across. Allows gas exchange. Hold on. Okay, I just wanted to double check so I wasn't saying that wrong because I wasn't raised with the metric system. Yeah, it's a micrometer or micron. Anyway, so very thin, half a micron, the thick that allows, because it's so thin, it's easy to get gases across. So you can take oxygen out of the air and put it into the blood, or you can take carbon dioxide out of the blood, put it into the air so you can breathe it out. The alveolar wall is a single layer of squamous epithelium, squamous because flat, because thin. That we call those type 1 alveolar cells. We also have the type 2 cells, which release the surfactant and antimicrobial proteins. I told you the surfactant keeps the walls of the alveoli from sticking together. All right, moving on. Other significant features, there are a lot of elastic fibers and pulmonary capillaries. Pulmonary capillaries because gas exchange. Elastic fibers because I told you the lung is like a balloon that you can inflate and then it will return to its normal size without you putting any extra energy in. Alveolar pores are passageways between alveoli. They equalize pressure through the lungs. They provide alternate routes for air to move in case if there's a blockage. You also have macrophages that live in the lungs, crawling around the surface of the alveoli, eating things that get into the lungs that shouldn't be there. 2 million dead macrophages an hour are carried from the cilia to the throat to be swallowed down to the stomach. Wow. Okay. So here we have alveoli and the respiratory membrane, and you can see the little yellow, thin, elastic fibers there. Good drawing. All right. And there's an electron micrograph of the exact same thing. You can see the capillaries. And underneath, you can see the surface of the alveoli. Okay, here's a nice drawing. I like this one a lot. Hint, hint. It shows the different types of cells in an alveoli. You can see the squamous epithelial cells, how flat they are, how they just surround the capillary, and you have the red blood cells going through there single file. So the type 1 cells, the squamous cells are there. The pores, those are the holes that connect, little passageways that connect the different alveoli. Here you have a macrophage, a big eater crawling around looking for bacteria that need to be killed. And somewhere here we should have a type 2 cell that's making, there we go, type 2 cells making the surfactant. Okay, good to know. Let's move on. So now we're talking about the lungs and the pleura. The pleura are the serous membranes that surround the lungs. They're slippery, full of that thin layer of fluid that allows them to move real easily. And so there's, we'll talk about pleurisy in a minute, but the pleura, because they're smooth and slippery, have that surfactant in there. Sorry, not surfactant, because they have that serous fluid in there. It allows them to inflate and deflate with less pain, less effort. All right, lungs occupy all of the thoracic cavity. except the little part in the middle where we have the trachea, the esophagus, the heart, that middle part being the mediastinum. The root is where the vessels and the bronchi attach to the mediastinum. The costal surface, costal means ribs, okay? So the anterior, the front of the thorax, lateral, the sides, the posterior, all of that, anywhere that you have ribs, that then the lungs are up against it, that'd be the costal surface, or I should say the pleura are up against it. The apex is the superior tip, deep to the clavicle. What they're saying is the end of the lungs right up here, just by the clavicle, that is called the apex. It's easy to remember because, do we have a good picture here? Yeah, we do. Okay, it's easy to remember because this apex, see how it's pointy? Well, if you remember, the heart had the pointy tip down and off to the left, but that pointy part on the heart was called the apex. Well, this pointy part on the lung right here is again called the apex. If you have trouble remembering that, look at the point on the letter A, the capital A. This point should remind you of the top of the letter A. That's your apex. All right, moving back. The base is the surface of the lung that is touching the diaphragm. So down here, the base at the bottom. I will not sing all about the base. Anyway, there you go. Moving on. The hilum is what we call the mediastinum, where blood vessels, bronchi, lymph vessels, nerves go in or come out of the lung. The left lung has two lobes, a superior and an inferior. There's a fissure, a groove between them. It's diagonal, so we call it the oblique, which means diagonal fissure. It's smaller than the right lung because we have the cardiac notch where the heart fits. The right lung is separated into a superior lobe, a middle lobe, and inferior lobe. It has both the oblique fissure and above that a horizontal fissure. Great. There's the pretty picture. Yeah, we've mentioned all that stuff already. Remember, costal means rib. All right, there is a dissected heart. You can see that lobes will be further divided into lobules. You know that the pulmonary artery is artery carrying blood away from the lungs. In this case, we're talking about low oxygenated blood we're taking to the lungs to pick up oxygen. But we have the pulmonary artery. Then we have here you can see, give me my mouse, thank you. You can see the cartilage on the bronchi. Anyway, left inferior. Yeah, we've got all of these, the only thing we haven't mentioned is aortic impression, and that's this groove right here where the descending aorta is going to drop. It'll be pushed up against the lung there. All right, here we have heart and lungs from above. Things we haven't mentioned yet: parietal pleura, visceral pleura. You probably heard these terms before. If you haven't, you're going to hear it when we do the digestive system too. Visceral, think very close. This is like stuck to the organ. You heard this on the heart too. Okay, so here, the pericardium on the heart, you'll remember we had the visceral pericardium and the parietal pericardium. The P in parietal reminding you that you were to the periphery. The V for visceral meaning you're very close, you're like stuck up to the organ, attached to the organ. So visceral pleura is very close to the organ, stuck to it. And parietal pleura is to the periphery, far, far, far away. In the same way, we have names for the pleura on the lungs. The visceral pleura is stuck to the lung, and the parietal pleura, the other side of that membrane, is away from the lungs, stuck to either the costal surface, the ribs, or the diaphragm down below. And just like around the pericardium, this is a very thin, kind of like a slit space that is filled with serous fluid. Slippery, makes it easy for the organ to move. That's the only thing I'm seeing there that we haven't mentioned before. So gross anatomy, each lobe is divided into bronchopulmonary segments. You have 10 on the right, you have either, somewhere around 8 to 10 on the left. They're separated by little septas, little walls made of connective tissue. Each segment has its own artery, its vein, and and a bronchus. If one segment is diseased, it could be removed individually without affecting the others, because they all have their own blood supply. Lobules are smaller than the segments, bronchopulmonary segments. So lobe, bronchopulmonary segment, lobule. Lobules look a little like a honeycomb because they're hexagonal, and they have bronchioles and their branches. Lungs are mostly alveoli. Anything that's not, we would call the stroma. They have elastic connective tissue. I told you it makes the lungs very elastic, stretchy, spongy. If you inflate a lung and then you take the pressure away, the lung will shrink back to its normal size, pushing the air out. That's what happens to you to every resting breath, every tidal breath that you take. All right, so there we have a cast of the bronchiopulmonary tree. They literally take a animal that's dead, like a sheep, and they fill the segments, the conducting zones of the heart, the conducting zones of the lung. They fill them with latex, fill them with rubber, and then they dissolve away the flesh, and you're left with these really cool casts. They look amazing. All right, so lungs are perfused. Remember, perfusion is how much blood you're sending through, how much gas exchange you do there, but perfused by two circulations. There's pulmonary circulation and there's bronchial circulation. So, pulmonary circulation, pulmonary arteries deliver systemic venous blood from the heart to the lungs, and they branch and feed into pulmonary capillary networks. That's great. The pulmonary veins then will return the blood back to the heart. You know all this, you've heard all of this. This is the one we sang about. The right atria is where the process begins, where the CO2 blood enters the heart, through the tricuspid valve to the right ventricle, the pulmonary arteries and lungs. All right, so yeah, that's, once inside the lungs, it dumps the carbon dioxide, picks up its oxygen supply, and it's back to the heart through the pulmonary veins. All right, so those veins carry oxygenated blood from the lungs back to the heart. Those veins are low pressure, high volume. The endothelium in the lungs, lots of enzymes that act on things in the blood. For example, angiotensin converting hormone activates blood pressure hormones. All right. We'll talk more about that in endocrine in a little bit. So, bronchial arteries send oxygenated blood to lung tissue. Do you remember we talked about the cardiac arteries supply oxygen to the heart, and the vasa vasorum, the vessels of the vessel, supply oxygenated blood to the blood vessels that are carrying blood? This is the same deal. We have the pulmonary circulation that is moving the blood through the lungs to pick up oxygen. Well, that doesn't help the bronchial arteries. The bronchial arteries are taking blood from the systemic side, from the left side, oxygenated blood being sent to all the conducting zone. So you can give those tissues oxygen. These bronchial arteries come from the aorta. They enter the lungs at the hilum. They're part of systemic circulation, so they're high pressure, low volume, and they supply all the lung tissue with blood except the alveoli. Remember, the alveoli are busy turning low oxygen into higher oxygen. The bronchial veins will anastomose with the pulmonary veins. What we are saying there is that there's a little bit of slop. The bronchial veins, the ones that are, oh, we've given up some of our oxygen, that blood will actually hook to the ones, the vessels will hook together. That blood will mix with the pulmonary veins that are super high in oxygen. And that mixture is what's actually being brought back to the left atria. Anyway. All right, innervation of the lungs. Lungs have both parasympathetic and sympathetic nerves, visceral sensory fibers. The nerves run through the pulmonary plexus on the lung root. We're talking by the hilum. They run along the bronchial tubes in the blood vessels. Parasympathetic fibers will cause bronchoconstriction. Sympathetic will cause bronchodilation. This makes sense. This is easy to remember. Remember, if you have to run from the bear, you need lots of oxygen. So you're going to use the bronchodilation. Another way of saying that, sympathetic fibers that give you the strength to run from the bear will also want you to open the passageways carrying air from the lungs so it's easy to deliver the oxygenated blood. All right. The pleura, double-layered serosa, divides the chest into two pleural compartments and one mediastinal compartment. Great. Parietal pleura, you have a membrane on the thoracic wall, the surface of the diaphragm around the heart between the lungs. Visceral pleura, the membrane is stuck to the surface of the organ. Got it. Got it. That's not bad. The space between the two layers of the pleural membrane is thin, super thin, like slit-like. But it's full of serous fluid, and that provides lubrication, surface tension. The surface tension will make it easier to expand the lungs. In other words, when the ribs move out, surface tension means they pull on the lungs, and the lungs also move out. So that allows intercostal muscles to move the ribs and pull air into the lungs. So great. That was assists in expansion and recoil. The expansion is the surface tension there. The recoil is when the opposite happens. The lung returns to its normal size without you putting in any energy, and that pulls on the pleura, pulls the ribs closer and brings them back. Anyway, so anything there? No, we're good. All right, so pleurisy is inflammation of the pleura. A lot of people get it from pneumonia. If the pleura are inflamed, they get rough, and then there's friction where the two sides are rubbing instead of having the serous membrane keep them slippery and smooth. They no longer move past each other easily. It hurts to breathe. Every breath will give you stabbing pain. The pleura may also make excess fluid, which can squeeze the lungs as it fills up that space, make it really hard to breathe. All right, other fluids that could accumulate in the pleural cavity. You could have blood that leaks from damaged blood vessels. Could have watery blood filtrate that comes from lung capillaries during leaks. You could have filtrate that leaks from the lung capillaries when left-sided heart failure occurs. All right, great. Pleural effusion is fluid accumulating in the pleural cavity. And that is the end of this PowerPoint. All right, let's stop. And